Hello, this is part 2 of a week 4 lecture. In this part, we will discuss staffing and scheduling and selecting, developing, and praising nursing staff. Let's review the objectives for part 2 of this lecture in the next slide. By the end of this class, you should be able to identify key external and internal organizational variables that affect staffing planning. Analyze activity reports to determine the effectiveness of a unit's productivity. Examine personal scheduling needs in relation to the patient's needs for continuity of care, and the managers need to create a schedule that is balanced and fair for all team members. Relate concepts of role theory to position description. Examine specific guidelines for performance feedback, and evaluate components of the coaching process to develop followers. In this part of the lecture that is related to staffing and scheduling, I'm going to use a scenario and case study. First, let's review some of the terms that are relevant to productivity. The NHPPD, which is a nursing hours per patient day, is a standard measure that quantifies the nursing time available to each patient by available nursing staff. The NHPPD reflects only productive nursing time. FTE measures of the work commitment of a full-time employee. The hours worked and available for patient care are designated as productive hours. Hours for benefits such as vacation, sick time, and education time are considered non-productive hours. Direct care is time spent providing hands-on care to patients. Indirect care, time spent on activities that are patient-related but are not done directly to the patients. Some of the staffing principles entails planning for staffing, defining or determining the staffing targets such as the NHPPD and units of service (UOS) that are discussed in the previous slide. Patient classification system, which is a measurement tool used to determine the nursing workload for a specific patient or group of patients over a specific period of time. Outcome analysis, which is determined by staffing effectiveness, and models of care such as staff ratios or RN percentage of direct care hour. There are new models of care that are being developed. Models are moving away from tasks to indices of performance or professional competence of nursing care for patient outcome. Let's look at this case study. You are a manager of an adult medical tele unit. You need to design a budget for your next year, and your budget is for an ADC, which is an average daily capacity of 40 patients. Nursing hour per patient day is 8.79 hours. RN to patient ratio is 1:4, and total full-time equivalence is 61.7. Now, because of renovation of the unit, your ADC, the average daily capacity, has been running between 28 and 32. The renovation is scheduled for at least 6 more weeks. Your staff is being floated to other units, and frustration is beginning to show. Staff are calling in, and your care model is eroding because you are having difficulty maintaining your RN to patient ratio. Let's review some of the solutions for the case and scenario that presented earlier. The staff scheduling council is called for an emergency meeting. The maximum average daily capacity is determined to be 32 for the next 6 weeks. The council seeks to remove frustrations for the staff and return to the care model that supports their patient care delivery. Units that staff have been floating to are contacted for their projected needs. Other solutions include that staff on units are required by skill mix and shift to volunteer for a scheduled reassignment. Staff understand the remaining renovation time and enough staff members volunteer to bring this unit staffing model down to 32. Other units welcome the known support with open arms prior to the shift starting, and the staff who are floating have less anxiety because they can plan better. Staffing and staff satisfaction can affect employee satisfaction, the cost to organization, quality of care. It also affects the quality of patient care. Some of staffing strategies that can be used are floating mandatory overtime, which can decrease employee satisfaction and the quality of care, and planned reassignments. Planned reassignments can improve satisfaction, decrease frustration, and improve quality of care. Retention can impact the satisfaction of patients, of clients, our employee. It also is costly for the organization. Several associations provide some guides to effective staffing, such as the Joint Commission, the American Nurse Association, and the National Database for Nursing Quality Indicators. These associations and others provide some guidelines for a better staffing and a patient outcome. Um, for example, Joint Commission has a staff effectiveness standard, HR 2.1. So the Joint Commission has initiated an effort to begin correlating an organizational clinical outcome data with its staffing ratio to determine the effectiveness of the overall staffing plan. The clinical or services and human resources indicators, uh, there are data on clinical services indicators that are used in combination with human resource indicators to assess staffing effectiveness. Examples of indicators that are used to assess effectiveness, some of the clinical examples are patient falls, the number of falls, uh, tracking the skin breakdown, the number of skin breakdown, and the length of stay, the LOS. Some of the human resource indicators are the NHPPD, which we discussed earlier in part 1 of the class, the nurse per patient, nurse hour per patient day, overtime, and vacancy rate. Let's review this case study. The length of stay was compared with overall nurse hour per patient day, the NHPPD, and the percentage of these care hours that was filled by an RN. When NHPPD were more than 9 hours and percentage of RN was less than 60%, the length of stay was extended. Data were used to budget a staffing model to bring the NHPPD to 8.5 hours and RN as percentage of care hour to more than 60%, with the length of stay less than 4 days. The goal of dealing with staffing issues is to use available data to improve outcomes. Staffing is about patient safety and positive health care experiences and outcomes. The next topic for this part of the lecture is about selecting, developing, and evaluating the staff. And if the quality of care is dependent on the quality and talents of staff, therefore, selecting, developing, and evaluating staff is a critical process. This is a key responsibility of managers and involves staff input in critical ways. What we will learn here will answer some key questions about why position descriptions are important, how to screen and select staff, what to expect from coaching strategies, how to appraise or participate in appraisals. This information puts the idea of selecting, developing, and evaluating staff in a context of role theory. In the role theory, role acquisition refers to how one takes on a new role. This aspect focuses on how to perform and what is expected. Role clarity refers to distinguishing the role from that of others. This aspect of role development refers to such tasks as seeing how the role of a staff nurse in Hospital A differs from the role of a staff nurse in Hospital B. Many people think of this aspect as a clarification of whose job is what. Role performance relates to how the role is actually enacted. The legal and organizational parameters are established by the law and the employer, but the insight of the role derives from the individual. So, when differences of opinions arise between two staff members about what to do next or how to approach a problem, in part the differences may derive from how an individual believes he or she must perform his or her role. Another aspect of role development is ambiguity, role ambiguity. In this situation, individuals do not have a clear understanding of what is expected of their performance or how they will be evaluated. Lack of clarity is frustrating in most situations and especially so in work settings. Role conflict is easier to recognize. Employees know what is expected of them, but they are either unwilling or unable to meet the requirements. All of these components about role theory are equally important for managers and followers. If anyone on the team is confused, the possibility exists that others may also become confused. To avoid role issues, select staff wisely, develop staff consistently, and evaluate staff fairly. Acquisition of a role is fairly time intensive. The role of the manager and the role and the other staff, or in the case of a new manager, all of his staff, is to be open and honest about how the role is seen and whether or not the performance matches the expectations. Two critical points about position description are these. Position description must reflect current practice guidelines and position descriptions beyond your own need to be understood. Position descriptions have to be analyzed on a regular basis to be sure they reflect what is accurate for practicing expectations. If they are not reviewed on a regular basis, they must at least be reviewed prior to opening a position for applications. Position descriptions play an important role in each of the key areas of selecting, developing, and evaluating staff. In developing staff, position descriptions serve to guide the educational efforts. In other words, if an individual is insufficient in performing the expectations of the role, those discrepancies, if educational in nature, form the basis for a remediation program. Evaluating staff obviously has to be based on a common understanding of what performances should be. Performances should be. Again, position description form basis for determining how able an individual is in meeting standard expectations. If, for example, a group of nurses not meeting a particular expectation, the manager must ask if there was an institutional failure to make clear what was the expectation, or if there was some distinctiveness to perform the role function. The manager should also consider if some change occurred that basically caused the position description to be outdated. Each of these areas require that the manager be actively engaged in coaching. As you can see, coaching is about developing individuals within an organization. It really can start in a simplistic manner during a selection process or an evaluation process, but its biggest impact and greatest energy focus on the development phase of staffing. Because coaching is a learned behavior, we all can become coaches. The challenge is that coaching is not a quick fix strategy, so sufficient time and effort must be devoted to it. Leaders, followers, and managers must invest in staff. They must recruit the best, hire the best, provide honest feedback, support desire to do the best. Without the best of the team, the best in nursing cannot be achieved. Thank you.